హలో చెక్.
వచ్చింది చూడు, లింక్ అవుతుంది.
హలో చెక్. హలో. So, very good morning, all the postgraduate students. Um, so, we have Dr. Bhavani Prasad with us. Now, to introduce Dr. Bhavani Prasad, first of all, I should say that he was the classmate of our chairman, sir, Dr. Bhaskar sir, and he hails from Kakinada. Presently, he is at New Jersey, and he is a pediatrician, sir. Huh? Pediatric critical care. So, sir is not new to us. For the pediatrics department, we have been interacting. All the pediatrics department is interacting with sir since quite good amount of time. So they and we should thank sir for really sharing his knowledge with us and motivating the students. And the students are very happy that for the sessions you are conducting, sir. So we named it as pediatric learning sessions. So they are very good. We are very happy. And today he has chosen a topic called the acute kidney injury. He has come to India, so he wanted to visit our place. I took this opportunity so that you all can listen to him. And thank you so much, sir, for being here with us. And now the mic is yours.
Good afternoon, everyone. Thank you, ma'am, for the wonderful introduction. Thank you very much. Thank you, sir, for this opportunity given to me. Thank you. I've been interacting with some of the pediatric residents who I can see here. I think I recognize Saba, right? Saba, right? Saba. Harshwa. You don't stand. Please sit down. Some of you I see on the picture, some I do not. So those of you who know have seen me, this is me in person. Been doing some pediatric sessions for you all for the last how many months? 7 months? 8 months? 8 months? 8 months. Are we learning anything from that? Is it good? Teaching has been my passion. I graduated from Rangarai Medical College And then I practiced general pediatrics in Kaikanada for a good amount of time, 1+ decades. Then I moved to the US and I redid all my training again. Did my pediatrics, went on to do pediatric ICU training fellowship, and I have been practicing pediatric ICU for 25 years now. Okay. 20 years in only one place and 5 years in other places. Once was in Chicago and New Orleans. So my specialty is pediatric ICU, and as you know, pediatric ICU we deal with all topics. I love congenital hearts. That's one of my passions. Mechanical ventilation is my other one, and of course, everyone says shock, so I should say shock too. So I know we have some pediatric residents here. What other specialties do we have here? General surgery. Good. I think you will also see this topic a lot. Anyone else? Gynec. Okay. Emma? Anesthesia. Any other specialties? General medicine, yes. Any other specialties? Interns? Nice. Very good. So interns are the stepping stone for the post graduation, or is it that's what it is? That's called the first years. So this topic, acute kidney injury, has not been chosen by me. It has been chosen by your colleagues who are sitting in this row, I think. And I think that is a topic that would apply to every specialty that we see. I think everything that I hear, I mean, I may not be talking to you more about pediatrics or internal medicine or anything, but the general concepts, I think, are the same for the across all the specialty for the acute kidney injury. Before I start, do you have any questions for me? Any pointers for me on what I should address upon? Feel free. Feel free to let me know what you think, what you want. Okay? Do not hesitate. We are all friends here. I'm not here to test you on anything. I'm not giving you any tests. We are not going to grade you on anything. Feel free. If you have any questions, please stop me, raise your hands, and we'll go from there. Okay? So while the clicker is getting ready, do you have any questions for me to begin with? Yes, Amma? No? Acute kidney injury in the pediatric population or in the general population. How many of us have taken care of children with acute kidney injury? Raise your hands. Don't be shy. Good. So I see only in the pediatrics. It's a very, very common problem. It's not an uncommon problem at all. And the biggest issue with the acute kidney injury, and it has been recognized now a lot more than in the past, if it is not recognized early and taken care of, you're going to let these children or any patient for that matter go into chronic renal failure and end stage renal disease. To begin with, we're going to have a little bit of a review on the anatomy. I don't know if you can see it clear here. And you all know this. I don't need to teach you what the anatomy of a nephron is and the kidney is. Right? Interlobular arteries, the veins, glomerulus, the collecting ducts, the loops, finally the collecting ducts, the proximal tubes. I don't need to go into the anatomy of this, but it's always important for you to know this because a lot of medications and tissue damage happen in this renal nephron. And if we do not know where the medications are acting on us, it will be very difficult for us to choose the right medication for a patient that is being presenting to you with an acute renal injury. This is again, and another, I don't think you can see it very clearly. This tells you everything what happens at each part of the nephron. You have the proximal convoluted tubule where the absorption of water, ions, and everything happens. Then from the capsular space, the glomerulus, efferent arterioles, afferent Bowman's capsule, and the pre-renal corpuscle where the production of nitrates happen. Everything like, this is a comprehensive picture of the entire function of the nephron. Very, very important picture for anyone who is dealing with an acute kidney injury in any type of patient. It tells you where exactly the problem is happening and how to address the problem in that particular part of the nephron. One has to know this part of it very well in dealing with AKIs. So what is the function of the kidney? Formation of urine, and the mechanism is by your secretion, reabsorption, and active transport. You have the next one, which is your acid-base balance, which is with your hydrogen bicarbonate ion secretions, maintenance of blood pressure with your RAS system, renin-angiotensin system, erythropoietin for your RBC production, and finally your calcium phosphorus by the activation of the vitamin D. That is what your vitamin D production and activation of that would cause your calcium phosphate balance. And what is AKI? An abrupt loss of reduction in the kidney function, decreased glomerular filtration rate, accumulation of BUN creatinine, and dysregulation of electrolyte and fluid hemostasis. This is what is defined as an acute kidney injury. Okay. 5 to 10% of all hospitalizations and 25% in the critically ill. So you can see how many patients you're going to see. For example, if you admit a patient of a DKA, if you did a BUN creatinine on all the DKA patients, you will see majority of them will have an early AKI. Patient comes in with a dehydration, diarrhea, dehydration. You check your BUN creatinine. I'm sure you'd have seen those BUN creatinines elevated in almost all the patients. A patient comes in with a septic shock. You will see that the BUN creatinine are elevated in these patients. So if you're looking at the critically ill, 25% of the critically ill patients will have an AKI. In a general population, patients are being admitted for any illness, you'll see that 5 to 10% of them will be having an AKI. It is defined as an increase in serum creatinine by zero point 0.3 milligrams per deciliter from baseline in 48 hours. Why do I say baseline? Because you might say, I'm checking my creatinine level in the patient today. The creatinine level, according to my lab, is 0.5 to, for example, depending upon the lab, 0.5 to 1.2. The patient comes in, his creatinine today is zero point 0.5. Tomorrow you check his creatinine goes up to zero point 0.8. Still within normal limits? Agreed? Patient has AKI, no AKI? Has AKI, no AKI? No. So the creatinine, as we all know, is immediately later. Yes, you're looking at this 48 hours. Oh my God. This is my problem always, right? When I teach, I always go forward a little bit. Increase in serum creatinine, you're saying within 48 hours by the definition. But once you see that, what is it telling you? That the nephrons, which have been working well, yes, you're right. If the patient is given a creatinine load, where does the patient get the creatinine from? Louder. TPN. TPN is a good source of the protein. Patient getting a lot of protein, but the patient is eating a big meal of meat. You probably, or if there's a breakdown of protein elsewhere, you can attribute that to the creatinine increase. However, a patient who has not been getting TPN or a big dose of protein, if the creatinine jumped up from zero point 0.6 to zero point 0.8, even though it is still within normal limits, watch out. That is the patient who is going to go into AKI. What happened here is you probably lost the function of about 20 to 30% of your nephrons. Going from zero point 0.6 to zero point 0.8, a jump of zero point 0.2, which is 30% of your nephrons, are damaged then. So a patient who is sick, who is not has other sources of creatinine coming in, if the creatinine has jumped up, watch out for that patient. That patient is going to be in acute kidney injury for you. However, if you did not have any of those, if it's a normal individual, then you're going to see zero point 0.3 milligrams from baseline in 48 hours, increase in serum creatinine more than 1.5 times the baseline in the last 7 days, and urine volume less than 0.5 mLs per kilo per hour in 6 hours, right? So where did this 0.5 mLs per kilo per hour come from? That's oliguria or anuria. In children, for less than 0.5 is anuria. Less than 1 ml per kilo per hour is oliguria. How did we arrive at this number? Why do we say I want 1 ml per kilo per hour? How did we arrive at that number? Based on the GFR. Okay. But why only 1 ml? Why can't I say 2 ml? Why can't I say 0.5, 0.6 or whatever? How did we get at that number? It makes sense if we understand what we are dealing with. Anyone? Anyone can give me a response. Anyone who wants to give a response, raise your hand. This is a good opportunity for me. When I'm doing the Zoom calls, I don't have this. Now I have an opportunity to quiz you. Emma? Okay. Anything else? Depending on the body volume. Okay. Wonderful. Great response. To excrete the minimal, the amount of solvent that is required to excrete the amount of solute. That is the minimum that is required. I'll give a very good example for that, for all of us to relate to. If you take a teaspoon of water, okay, and add a few drops of sugar to, I mean, few crystals of sugar, it easily dissolves in it. If I take a water, 1 teaspoon of water, and add 2 teaspoons of sugar, will the sugar dissolve in it? So what is my required for a particular amount of sugar, sugar crystals? You need a particular amount of volume of water to dissolve it. That's exactly this what we heard from this doctor here. That is the amount that is required, the minimal amount of solute that solvent that is required to take the solutes out of us. Our solutes are our UN, creatinine, toxins, and everything, and the water is urine. That's why the 0.5 mLs is the minimum. 1 ml is what we take in pediatrics. Adults, I think they take it 0.75 to 0.5. Am I right? Internal medicine, 1 ml. You take 0.75 mLs, right? Minimal requirement of urine output. That's what you normally do. That's what I remember from my medicine days. You also have a classification based upon the stages. Stage 1 is 1.5 to 1.9 times baseline, or a zero point 0.3 milligrams per deciliter increase in serum creatinine, or a urine output that is greater than 0.5 mLs, lesser than 0.5 mLs per kilo per hour. Stage 2 is 2 to 2.9 times the baseline, and stage 3 is 3 times the baseline, or a serum creatinine greater than 4. You have all your guidelines there. These are all from they had an international organization, KDIGO, right? You all know that KDIGO guidelines. Those are the guidelines from the KDIGO. And then you also have the P-rifle, pediatric risk, injury, failure, loss, end-stage renal disease. Great, P-rifle. It was first the adult, it was just a rifle. Then they made it for the pediatrics, it was slightly different. They developed the P-rifle guidelines for that, where you see that the patient have a risk is an estimated creatinine clearance decreased by 25%, 50%, 75%. Loss is persistent failure for 4 weeks, and end stage is more than 3 months. And you have urine. Here, mostly this becomes important than this for the P-rifle scoring. The creatinine clearance. And creatinine clearance is also very important for us to know. Why do we have to know the creatinine clearance in pediatrics particularly? Every patient who has got a suspected renal injury, creatinine BUN increases. You have to calculate your creatinine clearance using the online calculators, or you can use your Schwartz formulas and do it. Drug dosing, very good, because you want to adjust your drugs based upon your creatinine clearance. Some of the drugs, even with 25%, you need to adjust them. Some of the drugs, you have to wait until they're 50%. And some of them, you need to just space them out, okay? So that is why you need to know the creatinine clearance. Renal development and pathogenesis. They are not mature at birth. They begin at 5th week and continues up to 34 to 36 weeks of the development. Fetal urine contributes to the amniotic fluid. We all know that, right? If there is no urine, you have oligo. If you have more urine, you have the poly. Typically, it's not more, it's mostly less urine. We know that. Hypotonic in fetus, adult concentration is only by 6 to 12 months of age. That's why children put out a less concentrated urine. Their term infants have full number of nephrons, however, only 25% of the GFR and limited ability to concentrate urine. Okay, and the cardiac output to the kidneys is also very, very important. Why do we need to know the cardiac output to the kidneys in the children, pediatric practice? Because a patient comes in with septic shock, patient comes with cardiac failure, you need to know how much of your cardiac output is going to the kidneys. You want to divert that, you want to improve it, or you want to make efforts to save that cardiac output to the kidneys so that your kidneys can survive. So you can divert by doing a mechanical ventilation in a patient who is in septic shock, where the cardiac output might be decreased. You want to divert that cardiac output that is going into the lungs, to the lungs respiration. You want to divert it to some other essential organs. So if you look at it, 2 to 4% of the cardiac output at birth is going to the kidneys, and it goes up to 15 to 80%, 18% or 20% at 6 weeks of age. That's what happens. So I was asking earlier, where does the creatinine come from? Yes, muscle catabolism, protein in diet, urinary excretion. So our problem is urinary excretion. There is no urinary excretion, then your creatinine goes up. A patient comes in with a normal creatinine, bumps up tomorrow, please pay attention to the patient. Please pay attention to the patient. That patient is the one who is going into renal failures for you. What are the risk factors? You have all of them there. You have the volume depletion, infection, intrinsic renal disease, sickle cell disease. How often do we see sickle cell disease here? Do we see a lot of sickle cell diseases here? Really? You have a pocket of sickle cell diseases here? Tribal area. Newborns with low ABGAR scores and perinatal asphyxias, very low birth weight, low cord pH, mechanically ventilated, and cardiac surgery. I'm sure you're going to see all these categories of patients in your daily work in the hospital. Almost every day you will see patients in these categories. So all these conditions are risk factors for your acute kidney injury in the patients. Fluid overload is associated with increased mortality and morbidity. JAMA Pediatrics 2018, there was that was one of the benchmark studies that came out. People looked at the fluid overload and looked at the mortality and morbidity. If I'm able to attain a fluid balance at 48 to 72 hours in any patient, be it be pediatrics, be it be internal medicine patients, be it be cardiac surgery, whatever the group of patients, if we are able to attain a fluid balance by 72 hours, 48 to 72 hours, the mortality and morbidity are significantly decreased in these patients. Any patients where you are not able to attain that fluid balance, the mortality and morbidity are increased. That was a landmark study that came out, and every place follows that, to the extent that if they are not able to maintain a fluid balance by 72 hours, some of the institutes jump into going in for your renal replacement therapies at that point. Is it essential? No. We'll come to that later. RRTs are not essential for any patient if you are able to get a fluid balance by 48 to 72 hours. It is very, very important to get that fluid balance in these patients. The conventional definitions are your pre-renal, renal, and post-renal. I don't have to expand on all this. I think you all know about this. Okay. So what happens is this interplay of factors explaining the acute disease in affecting the GFR, right? So this might be a little bit of what happens is you have your ischemia, nephrotoxins, vasoconstriction, renin-angiotensin system, loss of autoregulation, activation of TGF, and the outer medullary congestion, decreased GFR, tubular damages. So you can see all of this. You have got the entire picture of what happens in the acute injury when that happens, how your GFR gets reduced in these patients. This might seem like, okay, we don't need to know all this. All I need to know is the management of a patient. But to manage a patient effectively, understand how it happens. If you know how it happens, you will prevent that from happening in the future, the patient. Pre-renal is diminished effective circulation. There is no structural renal damage. If perfusion is reversed, does not progress to intrinsic renal disease. And the common causes are your loss of volume in the patient with your hemorrhage, dehydration, sepsis, severe hypoalbuminemia. Any conditions that develops it gives you these conditions will develop into a pre-renal condition. And then you have your intrinsic renal conditions, your parenchymal damages, ischemic hypoxic injury, and nephrotoxic drugs, which are very, very common. Nephrotoxic drugs are very common. Can you name any nephrotoxic drugs? A few of them? Aminoglycosides? Yes. Yes. What else? Contrast, NSAIDs, amphotericin. Somebody said amphotericin. I'm looking for one drug. Vancomycin. Did somebody say that? Vancomycin. Vancomycin is how we use often. Vancomycin. MRSA patients. MRSA is common. How common is MRSA here that we use vancomycin? No? You see, our vancomycin is very. I'll tell you an example. I had this is my real patient. This is my real patient. How it is important for us to know how to take care of a patient. So we had a patient who had a VP shunt. And I like to throw stories real life stories here and there so that we can get that into us and prevent that from happening in the future. So there's a patient with a hydrocephalus who had a VP shunt. He has come in for a VP shunt infection, and the VP shunt was externalized. Patient was in the unit in the ICU, externalized dried. Patient had staph aureus in the VP shunt, started on vancomycin. 4 days later, somebody happened to do a chemistry on this patient. Now the BUN and creatinine, more than the BUN, the creatinine is sky high. Okay. So we went back and looked at the levels of the vancomycin. They're normal, within, not too high, not crazily high. Okay. The first day, third day, fourth day, fifth day, going up. The dose was not increased. What could have contributed to this patient's injury from the vancomycin? Can't hear. Sorry. From dehydration. Good. From what? This patient is in the ICU. The patient is getting IV fluids. The patient is being very well maintained. Where is the dehydration? It's a right response. He was not septic. The response is correct. Externalized VP shunt, not taking into consideration the amount of drain that is happening. Nobody paid attention to how much of fluid was coming out and not adding into the ins and outs of the patient. That's why the patient happened and went into vancomycin-induced kidney injury. Reversed. Okay. That's one story. That's something that you don't want to happen to any of your patients. I'll tell you something else that had just happened 5 days before I left my travels. Had a patient who has come in with strep pneumo meningitis secondary to H flu. And the patient, because we did not know what the organism was when the patient first came in with after the CSF was drawn, he was put on vancomycin along with ceftriaxone. So we wanted a level on the vancomycin on the fourth dose. Fourth dose, the level was drawn. The trough level of the fourth dose was 35. So we normally stop it, right? You stop and waited another 8 hours. We got a second. The second level was 65. So I said, you know what? Repeat the level again. So third sample, 100. So what do we do? Spacing of the drug. Real life situations. Very good. Patient is very well hydrated. Emma? Decreasing the dosage. Any other thoughts? Incorrect sampling. The patient had 3 IV lines. The sample was drawn from the same line all 3 times. The drug was sitting in the hub of the IV line. And every time someone went drew in the sample, they were drawing that medication that was sitting there. So after the third time, what did we do? Stick on an opposite arm, a fresh stick. The level was undetectable. So this is where problems arise. If you really trusted that levels, you would have stopped the medication. If the patient had a MRSA, meningitis, you probably would have caused more harm to the patient. So these are small things that we got to remember when we practice our medicine. This will not be taught in your textbooks. This will not be taught in your textbooks. Your professors will teach you, your assistant professors will teach you, because they would have gone through this a lot of times. That is where the experience comes from. None of the textbooks will teach any of these 2 scenarios that I just told you. AKI, we can always manage AKI. What is AKI? Just like patient has got an AKI, yeah, you see the BI and creatinine. If the patient is not having volume overload, You treat, when if the patient is overloaded, you give them a little bit of diuretic or stop your IV fluids. If the patient is dehydrated, give him fluids. That is the management. The bottom line, that is the end part of it. But how to get there and what are the practical points in managing an AKI is what you have to learn from what your professors are telling you. Intrinsic renal again is your glomerulonephritis, ATN, tubular necrosis, most common in the critically ill children. This is what we're going to see very, very commonly. ATN is one of the common causes of acute kidney injury in the critically ill patients. Hypotension, intravascular volume depression. Renal artery stenosis is not very common. Obstruction is also not common, but you will see that sometimes. Vasculitis, HUS. I don't know how often you see the vasculitis in HUS here. Decreased renal flow from cyclosporin, tacrolimus, ACE inhibitors, ARBs, which are very, very big now in the management of hypertensions and everyone, and the contrast agents. The newer contrast agents will not cause that much of a problem, but the previous contrast agents will cause a lot of problem. If you are giving a contrast in a patient who is likely to develop an AKI, what are you going to do after you give a contrast? Hydration, give them extra fluid for the next 6 to 8 hours so that the contrast injury nephropathy does not happen in these patients. Okay. I'm only using my computer because I can't see all the screen with my old eyes. Renal ischemia, what are your vascular effects? Increased sensitivity to vasoconstrictor stimuli, increased sensory renal nerve stimulus. All of these factors will go into developing your decreased, and this is from the Cribbin and others in 1990. It's an old one, but still the same mechanisms stay good. Medicine did not change since the time it started. A little bit. New advances in biologicals that came for the treatments, new advancements in diagnosing conditions, but the basics of medicine did not change. The brachial artery stayed the same. As I was walking through, I was reminded of my anatomy dissection days when I was coming here looking at the dissection. And it has not changed much. The brachial artery stayed the same, then median nerve stayed the same. It stayed the same position, did not change its position. Femur stayed the same. It might have become longer. Nothing changed. The way we look at it changed. The way we developed treatments has changed. Our understanding of the conditions has changed. And how did that help us to prevent further damage to the patient? So don't forget to go back to the basics of medicine. Always fundamentals are fundamentals. You cannot ditch our fundamentals. The next slide is a very, very busy slide, and I need to get closer to see what I'm talking about here. I'm talking about all the toxins for the myoglobinuria, hemoglobinuria, antibiotics, what are all the major endogenous and exogenous toxins that are causing acute tubular injury. These are all the groups of medications. This is a very, very busy slide, which I've taken it out of a journal. So it's going to be a very small print. And if you are interested, when I forward the presentation, you can go through it. I'm sure you know most of them. Renal vascular endothelial damage leads to increased production of endothelin 1, suppression of endothelial nitric oxide. We all learned that nitric oxide is of 3 types. Correct? Yes, no? Yes, it is 3 types. One is endothelial. Second one is inducible. Anos, inos, enos. Right? Neuronal, inducible, and endothelial. Endothelial is the one that is responsible for maintaining our blood pressures in a stable manner. Okay. Inducible is what you're going to see with septic shock, where you want to maintain your blood pressures, it acts up. And NOS is in the neuronal ones. Okay. Activation of leukocytes and promotion of leukocyte addition. Injured cells lose polarity and subsequently lose the tight junction. Whenever you lose your tight junction, that's when there is going to be a leak of fluid. That is when everything goes out. Septic shock, you got a tight junctions become loose, water leaks out, fluid becomes, third spacing of fluid happens. Same thing happens here. This is again a graphic of multiple biochemical pathways that lead to cell necrosis. You have got ATP depletion, increased cytotoxic, free calcium. I'm not going to go through all of them because this is for you to know how to go that and know what causes the damages. You got the severe ATP depletion, decreased, and release of arachidonic acids, oxidative DNA damage, DNA degradation, disintegration of lipid membranes, the release of cytosolic, lysosomal, and nuclear components, injury, and final pathway is your loss of your cell integrity in all these pathways. The next one is also going to be this also tells you about what happens in the tubular epithelial cell injury. There's a normal epithelium. Then you got the loss of polarity. When the loss of polarity happens, you got your cell death that happens here. And then your cell death, there is a sloughing of viable and dead cells that cause the luminal obstruction, leading on to damage and obstruction of the glomeruli. That's what on the tubules. That's what happens with your pathology from that. Tumor lysis syndrome, another cause of acute kidney injury from lysis of cells, uric acid obstruction of the tubules, acute interstitial nephritis. How many times do we see tumor lysis syndrome? Anyone seen tumor lysis syndromes? What is tumor lysis syndrome? Can't hear among. If I can't hear, they can't hear. Okay. Sure. So after starting chemotherapy, the cells lie down. So do we need to wait for this chemotherapy to be started for the tumor lysis to happen? No. So we cannot say after starting chemotherapy. Any patient who comes with a huge malignant cell load, most likely with the leukemias, you don't need to wait for chemotherapy. The destruction of the cells causes the tumor lysis syndrome, commonly seen. What do we do in tumor lysis syndrome? Hydration, electrolyte correction. What electrolytes do we have in the disturbances? Even though this is an AKI, I just want to like touch base on whatever comes to my mind. Hyperkalemia. So you don't give any potassium containing fluids to these patients, right? We always maintain no potassium in the IV fluids. Monitor that. What else do we monitor? Most important, sir. Cardiac monitoring. Most important substance to be monitored in uric acid. Uric acid is the substance that causes this destruction, right? So you want to monitor uric acid on a regular basis. And I do not know if you have a raspberry acid here. If you have one dose of raspberry acid will do it. It will take care of that uric acid. Because the uric acid comes from the destruction of the cells, the DNA, the nuclear material that causes the production of this uric acid. The two ways of doing it, one is by giving allopurinol, the other one is by a raspberry acid. The difference being raspberry acid will get that uric acid out, whereas the allopurinol will decrease the production of it will take about a few doses of the allopurinol to be given, whereas the raspberry acid will act immediately. Just one dose of raspberry acid will do that. And then you have your post-renal causes, which is obstruction of the urinary tract, posterior urethral valves, uretropelvic junction obstruction, stones, and tumors. What do we do? A careful history, a very careful history. Child with diarrhea and vomiting has probably dehydration, but also remember HUS. Because diarrhea can result a result of a bacterial infection that can result in HUS. Then you have your pharyngitis. Remember post-infectious glomerulonephritis. Creatinine elevation happens 48 hours after injury. Don't expect the creatinine to boom rise up right away after an injury. It can wait 48 hours before it happens. Hypotension, drug exposure, you all talked about it, contact exposure. A thorough examination of the patient, attention to volume status, look for rashes, look for palpable flank masses. Why do we have to look for rashes? What do the rashes tell us? HSP, very good. SLA, SLA, HSP, HLA, SLA, HUS also. Can HUS cause a rash? Yes. Hemolytic uremic syndrome. Can it cause a rash? Yeah, hemolytic uremic syndrome. It can cause petechial rashes. So you want to look for any rashes in these patients. You have to look for the hydration status, uveitis, meningitis, and JVP. Why JVP? Cardiac failure. Patient with cardiac failure, you're going to watch for JVPs. You have to do a complete examination on a patient. People, nowadays, we have come to the point where we depend more on labs, testing, not our physical skills. These guys, I'm sure, have a lot of the physical skills, the art of medicine. The art of medicine is probably dying as it goes backwards. Like, as the new generations come up, the art of medicine. You agree with me, sir? The art of medicine is dying. We did the diagnosis. You all did do the diagnosis without any testing. You come and diagnose a condition without any testing. But nowadays, it is all labs, labs, labs. And AI added on to the labs now. The lab will tell you abnormal, highlighted in red, not knowing that could be a normal for that patient, for that age. The lymphocyte count should be 60%, 60.5% red highlight. Patient goes home, looks at the Google. It says red, red says high. High is I'm something going on with me. And they will stop you from doing anything. You know that there's a new name for that? The new medical term for that, what the patient comes and stops you from treating them. It's called the idiot syndrome. Internet derived information obstructing therapy. I'm not kidding. This is a new terminology that has been developed. It is in parlance. You can Google it now. It is true. It is come out. This is now accepted. Internet derived information obstructing treatment. What are the labs you're going to do for the patient? You're going to look for your CBC. You're going to look for anemia. You're going to look for thrombocytopenia. You're going to look for leukopenia. You're going to do a chemistry, complete metabolic panel. You're going to look for hyponatremia, metabolic acidosis, BU, and creatinine. Basically, what are we doing? We are looking what the function of the kidney is, and we are looking at if any of those functions is being affected by the injury that happened. You're looking at the uric acid for the tumor lysis syndrome. You're looking at the serum C3, C4 levels to say if there is any SLE or no SLE or if it's an acute post-glomerular nephritis. You're looking at urinalysis, you're looking at hematuria, proteinuria, RBC, which suggests acute kidney injury. And you're looking at urinary eosinophils, particularly in drug-induced fevers. Drug-induced. Patient who comes in, you treat him with for fevers, for infections, you give them antibiotics. Patient is clinically doing well, but the fevers don't go away. After 10 days, 15 days, what do we you keep on culturing the patient? The fevers are still there, the cultures are negative, negative, negative. Drug induced fevers. The characteristic feature of a drug induced fever is a urinary eosinophilia. That is a very characteristic finding of a drug induced fever. Okay. So we all need to know that because we treat sometimes with this sepsis, we give them antibiotics so much, and by the time you're done with it, the patients are continuing to have fevers with that. There are certain categories of patients which need prolonged antibiotics. Patients with pneumonias, patients with pleural effusions, empyemas, patients with meningitis, depending upon yes. So we patient sometimes after that, to give like 2-3 weeks of antibiotics, they still continue to have fever. Every time the EVD cultures come back negative, but the patient is having a fever. And until those fevers go away, ID will not clear for the shunt to be internalized, and neurosurgery cannot internalize them. The neurosurgeons will keep telling us, no, after 2 weeks, oh, this is drug induced. ID will say no. The only way that we can say yes or no is to do a urine test and see if there is any eosinophilia in these patients. And then we look for the renal indices. Pre-renal is elevated specific gravity, urine osmolality of more than 500. That's what you're going to see in the pre-renal acute kidney injury. You're going to see a urine sodium less than 20 milliequivalents per liter. Okay, if it's a pre-renal, and FeNA is less than 1%. How do we calculate FeNA? Fractional excretion of sodium. We have got the MD calculators. Put the numbers on the MD calculator and the MD calculator. Don't ask me because we also do that. Everyone does it nowadays. It's easy for us to do that. Renal injuries will be a specific gravity of less than 1010. Your urine osmolality is less than 350, and your urine sodium is more than 40. That's your renal injury, acute kidney injuries from renal intrinsic renal disease. And your FeNI will be greater than 2%. That is, one less than 1% is pre-renal, more than 2% is acute renal injury. You also have to do an EKG to look for hyperkalemia, resulting in what do we see in hyperkalemia on a EKG? The interns, right? You're all interns. Tall peaked T waves. Very good. Very good. Going to say renal ultrasound. What are we looking for in the renal ultrasound? We are looking for any enlargement of the kidneys. We are looking for any uh, echogenic lesions in the kidneys. You are going to see if you add a Doppler to it, you're going to see the renal flow to the kidneys. You're going to do a GFR increase from 40. You can calculate your GFRs. That's why, okay. And then your renal biopsy will tell you if there is a long-standing renal disease. So you probably have to do a renal biopsy to diagnose the condition that is resulting in your kidney injury. Serum creatinine is a late indicator. Just like your blood pressure is a late indicator of hypotension, first thing is your tachycardia. Blood pressure happens, you're already crossed the limit. Similarly, serum creatinine, you may not see it early. That's why I said, if you see a small bumps, keep an eye on that. So serum creatinine is a late indicator. Now the newer ones are coming up. Then there are a lot of new tests that are coming, particularly what is the tissue inhibitor of metalloproteinase, which indicates cellular stress. And you also have the NGALs, urine neutrophil gelatinase associated lipocalin. These two tests are being more frequently used nowadays to diagnose kidney injury even before you see the manifestations of the disease happening. It has picked up significantly in internal medicine. They are doing a lot of these tests. It has been calibrated. It has been approved for that. Pediatrics, we're just starting to do it. We don't know how far they're going to be coming much into practice because there are some things that happen more in the adult world than in the pediatric world. But in the adult world, they already are using these two TIMP2s and NGALs on a daily basis, on a routine basis to diagnose kidney injury before it happens. And this is both those they should not be bulleted here. This is all from the current opinion in pediatrics 2020. If you haven't read this article, this is a very good article. Indian Journal of Pediatrics 2020. That's a very good article that came out in acute kidney injury in the pediatrics, and that is referenced in almost every study that came out on the kidney injury. That's a very good article that came out. Management. Foley catheter. Number one is to put in a Foley catheter. Okay. Who made the first Foley catheter? History of medicine. History of medicine. First stethoscope. First stethoscope. Who made the first stethoscope? We have to be thankful to our forefathers and ancestors. Once a year, we pray to our fathers, our grandfathers, our great grandparents. Medicine, we have to thank our forefathers in medicine who gave us the life that we have. The life that we have today, the life that I have today, the life you're going to have tomorrow as practicing pediatricians, practicing internists, practicing OBGY, whatever field we go into, that we're thankful to them. The common answer I get is, who made the first stethoscope? I hear, I hear Littman is the common answer that I always get. Linek, Linek. But Littman is not Littman. Foley was the one that first designed the Foley catheter. Foley catheter was designed by him. Volume expansion, CVP might be helpful. Central venous pressure should void in 2 hours after volume expansion. This is a very, very common question that you will hear from the nurses. I've given a fluid volume, I've given a fluid bolus. The child has not peed 20 minutes after the bolus. No, it's not going to, because the urine has to get, the volume has to increase, it has to get filtered at the kidneys, get drained in the bladder, and then the bladder has to fill up, unless the patient has a Foley catheter, the bladder has to fill up to its capacity before the patient can pee, right? So it takes about that much time. You have to wait 2 hours, and failure indicates intrinsic renal disease, or the patient is not adequately volume replenished at that point, either of those two. Press sauce may be needed for sepsis-induced hypertension. Diuretics are only given after adequate volume expansion. Do not give a diuretic before the volume is expanded. You're going to run these patients into kidney disease, acute kidney disease, if you do that. Bumetanide, furosemide can be given as a 2 to 4 milligrams. I don't know what doses you give in the renal dose failures. People normally 0.5 to 1 milligram per kilogram. But if you're really suspecting an acute kidney injury, hit them with a big dose, 2 to 4 milligrams per kilogram. One big dose of furosemide, they will pee. If they don't pee, then there is some other problem going on at the time. Bumetanide is another one, or you could also use a Lasix as a continuous infusion. 0.5 milligrams per kilogram as a 0.1 to 0.5 milligrams as a continuous infusion, particularly useful in patients who have got cardiac surgeries and other conditions. If no response to diuretics, that's when you restrict your fluids to 3 to 500 mL per square meter per day. That is your insensible fluid losses. That's the amount of insensible fluid losses that you have. 300 to 500 mL per square meter per day. That's your insensible. Treat your hyperkalemia. A good time to review hyperkalemia management. We did this. We did the talk. Yes. Step number 1. Hyperkalemia management. Step number 1. I want to hear loud and clear. Step number. Someone is very, very good here. You're the staff. Postgraduate. 3. That's fine. Stop all potassium containing fluids. Very good response. That is the first step. First step. As a matter of fact, the pediatric board, American Board of Pediatrics, they conduct this board tests for everyone who's graduating. One of the questions is, this is the question from their boards. What is step number 1 for management of hyperkalemia? They give you all the responses that you just said. Calcium carbonate, calcium gluconate, not carbonate, calcium gluconate, bicarbonate, insulin glucose, stop all potassium containing fluids. The response is potassium. First is potassium containing fluids. And then you go for you do a lot of things simultaneously. Simultaneously, you want to repeat your potassium levels. Then you give the calcium gluconate, as I said. That's 50-50. Some people use it, some people don't use it, but I use it. Okay. Next is always your nebulization. Okay. I would put it a little bit down. Pediatrics, adults, yes. Adults, albuterol, salbutamol inhalation is very frequently used. It works very well in adults. In pediatrics, it's not that great. Insulin dextrose. And you can stop reabsorption of potassium by giving them binders, KX late. low-calma coagulate resins. If everything fails, bicarbonate. How about bicarbonate? Not everything fails. How about bicarbonate? Should we give bicarbonate for hyperkalemia? Yes. How does it work? But they're all listening. They don't know. How does it help, Amma? It pushes it back into the cells, right? Yes, very good. Very good. So potassium is pushed back into the cells by the bicarbonate. By giving bicarbonate, by correcting your acidosis, you're going to push it into the cells. If everything fails, then you go into for dialysis. Nutrition is very, very important. Protein up to 3 grams per kilo per day. Do not restrict for urea up to 80 milligrams, because a lot of times what we say is renal failure, stop your protein, don't give them any protein. Don't do that. They're going to be in a catabolic phase. If the BUN is going beyond 80 milligrams, that's when you start restricting your proteins. 0 to 2 years, you want to give them 2 to 3 grams per kilo per day. You have all your numbers there for how much of protein to be given. You need to give them good amount of calories, 125 to 150% of their normal caloric requirement. Early enteral feeding, reduce carbohydrate intake if on peritoneal dialysis, because the peritoneal dialysis fluid contains dextrose in itself. So you might have to decrease your dextrose. 20 to 25% of carbs and 30 to 40% as lipids. That should be your nutrition for these patients. Adjust medication dosing. Somebody mentioned here that we need to adjust the medication dosing, and that is very well written in your, what book do we follow here for the medication dosing? MIMS or Harriet Lane? Follow Harriet Lane. Harriet Lane has got a very good chapter on, last few pages on the drug dosing and everything, renal dosing. So everyone follows Harriet Lane here. It's a good book. You read that Harriet Lane from page to page, you're covered about 70% of pediatrics. Everything is covered in there. Couple of other points here. Maintain adequate renal perfusion pressure. Your mean arterial pressure should be well maintained. What is the goal mean arterial pressures in pediatric patients? Let's talk where we know. How about in adult patients? Mean arterial pressure that you want in MAPS in 60, 55. Adults, 65. Yes, very good. 65 to 75 is, we want 75 is what they want. How about pediatrics? No set rules. No set rules. So nobody did really studies. So we say we take their numbers, extrapolate into pediatrics. We say we'll take 60 to 65 in older children. Infants will say 50 to 55. You want your maps to be, you want to maintain your mean arterial pressures. Vasopressin is not shown to increase renal perfusion pressure. Vasopressin is commonly used in septic shock patients. Okay, how often do we use vasopressin here for the septic shock patients? You use them, right? So it's not shown to do that. There is no evidence for the benefit of dopamine. Dopamine for the renal dosing is out. Dopamine for low blood pressure, septic shock is also not the number one choice nowadays. It used to be, but no longer. Only norepinephrine is shown to improve renal perfusion. How does it do that? Did we get to a stop it and shock? I think we did. How does norepinephrine improve the renal perfusion? Sorry? Dilatation of the afferent arteriole. It dilates the afferent arteriole. That's how it does it. Emergency management is a fluid bolus with normal saline, lactated ringers, or PRBCs. In cardiac disease, small volumes repeatedly. We all know that you don't want to give a big volume at one time to any of the cardiac patients. And vasopressin, vasopressors, not vasopre. That was probably I was in a rush to do it. So dialysis is only indicated if there is an anuria, oliguria with a fluid overload. Volume overload that is refractory to diuretic therapy, persistent hyperkalemia, severe metabolic acidosis that is not responding to medical management, uremia, and calcium phosphorus imbalance not responding to other measures. Talking about calcium phosphorus balance in kidney injury and renal failure and acute renal failure, what are the things that we need to remember when we are looking at the calcium levels and phosphorus levels in kidney injury? Patient comes in, kidney failure, renal failure, total calcium is 6.5, ionic calcium is 3.5, the normal is 5, the patient's phosphorus is 10. Here is something here. Someone was saying something here? No? Yes. Patient comes in renal failure. Patient has a total calcium of 6.5 with an inus calcium of 3.5, normal being 5, and the phosphate is 10. What do we do for this patient? Should we give him calcium? No, because phosphate is going to precipitate in the tissues, right? So you look at the calcium phosphate product. You want your product to be less than 60. Only if the product is less than 60, you give them calcium. If it is more than 60, you don't want to give them any, unless the patient is symptomatic from hypocalcemia. Then you have to very gingerly give them a little bit of calcium so that they are not going to have the calcium hypocalcemia symptoms developing. So remember that any patient coming in with a renal failure, you want to make sure that your calcium phosphate product is less than 60 to give them calcium treatments. Okay. Peritoneal dialysis uses. I'm going to go very briefly on the renal replacement therapy. This is a completely different topic. If you're not doing on a daily basis, you don't need to know entirely about it. Know a little bit about it. PD uses vascular lining of the peritoneum for its the clearance of the fluids. Hypertonic solution in the peritoneal cavity creates an osmotic gradient, allowing for fluid shifts and fluid removal. Solutes are cleared by concentration and considered in infants and critically ill children. It is one of the methods of treatment of, institution of RRT in infants because it's easy to do. You don't need a big vascular access. It can easily be, lines can be easily placed in the belly and it can be done. It can be, the lines can be placed at the PD catheter can be placed at the bedside and the patients can go home and continue PD at home as of the other forms. Advantages is very well tolerated, relatively easy to perform. It can be done at home, no vascular needed, no heparin needed. Disadvantages, it's not as good as clearance for other modalities. Skin infections, congenital anomalies of the abdominal wall and contents. Procedure related, catheter migration, infection, peritonitis, hyperglycemia. Because the fluid that you use in your PD dialysate has got dextrose 1.25 or 2.5%. So that might cause your hyperglycemia in all these patients. The other one is your intermittent hemodialysis, where the blood and dialysate running in countercurrent manner, just as in your kidney. The kidney, the same thing happens, right? Countercurrent measures. Efficient removal of solutes, and it's not very well tolerated in critically ill patients. When I say that, in critically ill patients who are hemodynamically unstable, hemodynamically stable, they are okay. Critically ill patients, hemodynamically unstable, IHD, the hemodialysis is not that very well tolerated. It requires a vascular access. It needs a heparinized circuit, so you need to watch for bleeding from other places. And complications would be infection, catheter block, and hypertension. One factor that we all need to remember with hemodialysis, intermittent hemodialysis, is timing and drug dosing with regards to the dialysis. If I give a medication and do a hemodialysis right after, the drug is out, it's eluted, right? So you don't want to do that. You want to finish your hemodialysis session and then give them a dosing on the medication. So you want to know that, because sometimes what happens is you do this hemodialysis in patients who are sometimes septic and you're giving them antibiotics. You do the antibiotic, you give them an antibiotic, you do hemodialysis, your antibiotic is completely out of the system. It's as useless. So you want to make sure that the drug is given after the hemodialysis is completed. This is a picture I think I have of the dialysis catheter in the circuits, how they do it in the CVVH, the veno-venous, veno-arterial, and all. And this also shows you the same canister, the filters that we do that, and how it goes, the complete system, how it is, just for the pictorial of how the solutes have to go in and the dialysate comes out of this. CRRT, the other one, is the three different types you have. The CVVH, which is the clearance by convection, CVVHD by diffusion, and CVVHDF is both convection and diffusion. That is the most common thing that we normally use nowadays. May be used in hemodynamically unstable and increased fluid. It's a very, very safe method in patients who are critically ill in the ICUs at any time. Any patients we can use that. Prognosis is variable and depends on underlying disease rather than the renal disease. Complete recovery unusual if rapidly progressive glomerulonephritis, renal vein thrombosis, or bilateral cortical necrosis. So that is AKI in a nutshell. I know you have managed the AKIs very efficiently up to this time. It's just a refresher, not that you do not know anything about it. A lot of times we need to hear a few times before it gets imbibed and ingested into us. Just like a third-year resident knows what to do for a hyperkalemia versus an intern. That's because you have done it so many times, you already got it boom like this. Whereas the first years were starting mid school, you just learn. I'll tell you my story when I was a long time ago. So I hail from Kakinada, and I was a second year medical, no, yeah, second year medical student, still doing my anatomy physiology. And the person who was behind my house, he was a second, fifth year, that he was in his medicine, like the fifth year medical school. In those days, it was 6 years. Mine was 5 years. So he was a 6 year course, 2 years anatomy physiology and 2.5, 3 years, and then like totally forgot. So talking to him, he would talk to me about all the medical conditions and how to treat. I would look at him in awe and inspiration and wondering, how does he know so much of medicine? I don't know anything. Should I quit my medicine? Wait until you go, you get into medicine, you start doing it, you practice years and years and years. It is easy for us to say, this is how you do it. It is not reprimanding you. It is giving you a jump start so that you learn from people who have already gone ahead of you, who are ahead of you, get their experiences, take off from that. You have a launching pad. We don't have a launching pad. You would have a launching pad. You take off from there. So it becomes a matter of fact after you practice medicine a few years. If you go start doing it, understand the physiology, understand everything, develop the compassion, listen to a patient, compassion, patient, listen all that. Pay complete attention to a patient. Do not write off whatever they tell you. Oh, I know more than you. No, patient is the one that is suffering. If they tell you something, you have to listen to it. Particularly in our branch, pediatrics. My favorite story, I mean, my favorite relationship is like we get patients. Do the patients come to us out of their own volition? Do they come to us out of their voluntarily? No. If they go to an intern, is they go, I want to go see a particular doctor, I go see the particular doctor. I'm making the decision. When they come to you, the parents bring a child to you. And what is a child to a parent? Is the child worth more or less than gold? Is a patient worth more or less than a diamond? Is worth more than anything that the world has for the parent. If they're bringing a child and putting that child in your lap, in our lap, wanting them to be treated, how do we treat them? You have to, everything that we have for the patient, everything that we have. Okay. No matter what we undergo through the process, we have to give them everything, because that patient did not come to you out of their own volition. The patient has been brought to us by someone and left with full confidence in us. No matter what you do, whatever you do, and yes, money is important. I'm not saying money is not important. We all have to eat and live. We have to bring up our families. Once we take care of our patients, money will automatically follow. That will come. Don't do things that for the sake of money. Insurance companies have come in, and the insurance companies make us do, at least in the US, they make us do things that we don't want to do for the patients. I don't know much about what is happening here. Okay. Help everyone. Wherever possible, I'm just diverting from the AKI to other things about medicine. Okay. Wherever possible, give back to the community, give back to the society. Go ahead and do what you can. Either within your community, go outside the community. Help everyone. Don't hurt anyone. Okay. Help, love all, serve all. Um, I go out on medical missions sometimes. Okay. I travel with the Baby Heart and the Gift of Life International doing the charitable cardiac surgery programs. So at least once a year I go out with them. Do what you can. It's not that they pay me anything. I use my vacation time to go there. But that gives me a lot of immense amount of happiness. Seeing a child that did not get a care anywhere. I just went to Guyana, came back in December. I told you, I think, at the time. So we did cases there where they don't have access to medicine, like what we have. We have access in India. India is a very good place, very well developed with regards to cardiac surgery and other things. We are on par with everyone here, but other places don't have that. Wherever possible, try to do that. Any questions for me? Any questions, sir? No, they are doing everything, but it's just putting everything in a nutshell. That's all it is. Any other questions apart from AKI for me while I'm here? Anything else apart from AKI? Apart from medicine? Any questions apart from medicine? Okay. Good.
Anybody wants to discuss anything else besides this? No, nothing. You don't have anything to ask. Anything, whatever you feel like. Interns? Don't want to know anything? Hmm? Nothing. So we'll close. Raise your head so that you'll understand what I am saying. కొంచెంసేపు ఆపమ్మా మొబైల్ నువ్వే ఆపేసావా ఏమైనా ఉన్నాయా అడగడానికి ఏం లేవా ఓకే సో డాక్టర్ సుధీర్ సో హీ ఈస్ డాక్టర్ సుధీర్ హీ ఈస్ ద ఫౌండర్ ఆఫ్ దిస్ మెడికల్ కాలేజ్
Because my students are not asking you anything, I just put you one question. Do you want our students after finishing their post-graduation to go abroad and learn something more, or is it India is enough for them to get trained and utilize their services?
To go abroad or not, the question comes up in everyone's mind. But we have enough resources here to do what anyone else can do anywhere else in the world. To be honest, commitment, I want to do the best for my patient. I will tell you, I can tell you between the two worlds. I practiced here for 13 years, then I moved to the other country. Okay? For various reasons, for personal reasons, I had to go. And the difference that I found, sir, is we learn a lot here, but when it comes to practicing medicine, when I practiced, I don't know how it is different nowadays. Patient comes in, fever. We do not even look at what are all the pathogenesis that goes on at the time. Just give them some antibiotic, give them some paracetamol, send them home. Not going into the details. The days have changed, the times have changed. We have a lot more resources now where we can dig into the diagnosis. If that commitment and learning and eagerness to treat them completely is there, there is no reason to go somewhere. All that everyone does anywhere else in the world. If you look at the renal injuries, if you look at the CRRTs that everyone keeps talking about in every place, we do that here. We don't need to go abroad. Patients come in with pulmonary hypertension, nitric oxide, it is done here. High frequency oscillators, they are done here. We do everything that is available everywhere. The only thing is we need to have the commitment and the resourcefulness to get the information, train ourselves here, and put that into practice. When I started, this was many years ago, and I don't say that you should go back in time. When I was doing my pediatric training, we had no training in exchange transfusions. Nobody has done an exchange transfusion. And myself, I mean, another postgraduate student with me and myself, we decided we need to get to learn to do the exchange transfusion. So we pulled up manual of neonatal therapeutics. Is it still there? Boston Children's Hospital has a manual of neonatal therapeutics. They have a small book that used to give everything in there. Took out that book just like your Harriet Lane. One of us was reading the book, the other one was just doing step by step by step. We did not have the umbilical catheters. We did not have the sterile syringes that we have right now. We used a feeding tube, 5 French nasogastric feeding tube. Read the manual of therapeutics, cannulated the umbilical vessels, and did the exchange transfusion. So, commitment. I'm not saying that I am committed. I'm not. If you have the commitment, they don't need to go. Even if they go, they need to come back. People here need a lot more help than other places. It's not like that they need to go somewhere.
I put that question specifically because I want to get the truth from the horse mouth. Then it will be believed. I still believe, as on today, India is second to none in this world. We have reached to that stage. Whatever you want to do, you can do it in India. Whatever you want to be to achieve in your life, you can achieve it in your life. And the opportunities to serve more people is more in India when compared to others. And there are many countries, many countries, many places, even in the developed countries, which are not having this much of access to the healthcare. That is the truth and fact. So don't look down at India. Don't run away. Please be here. Specialize. The only thing is the commitment. If you have that commitment, India is a place where empty number of opportunities, empty avenues are available. So only, as he rightly said, it's the commitment that is more important, not the place. Anything. Thank you so much, sir. On behalf. Yes. No, no. This is I never underestimate or undermine the people others who have gone there. The situation is different those days. Now the India is far developed, far well developed when compared to. See, any technology that is coming into the Western world will come to India within 6 months. I'm telling you, within 6 months. Now the government is giving assistance. People are bringing this technology within a very short time. And once upon a time, it's not like that. Used to that's why the place were better in those for training those days. The abroad we used to go. That is the right time. Now this is the I'm talking about 2025. That is the now we are no way second. We are second to none. I'm saying. Thank you so much, sir.
On the same note, I want to say, like, I work with an organization which used to be called the Baby Heart. Now, then it became the International Child Heart Foundation, and now it is the Gift of Life International. So what they do is they go around the places where there is a dearth of cardiac surgery for the pediatrics, provide pediatric cardiac surgeries. They take a team of 15 people, which includes the nurses, the ICU physicians, and the surgeons, and they do it. I think it was in the 2012, 13 time. At that time, there was a request for the team to come to India to help in Hyderabad. So I came with the team 3 times. The first time the team came, it was a full-fledged team of 15, 17 people that came there. Did the cardiac surgeries in Hyderabad, pediatric cardiac surgeries. We did about, in a week's time, did about 15 or 20 cases, went back. When we went back, when we sat for the debrief, the team leader said, I don't think these guys need much of our help. Second time, 6 months later, the team came again. Instead of 17 people, it was only 10 people that came. And at that time, the surgeon who was working with them and the local surgeon, the surgeon that came from abroad was learning some of the improvised techniques that are being implemented here rather than the other way around. And the third time, it was only just 3 people that came, and they said, "You don't need us anymore. In fact, there was actually no need for any one of us to come here to train you. You guys are very well trained. You work like machines. You do excellent work." So that is the care that is provided. It's not just one team. I go to any other place, they tell us, the Guyana I was just talking about in British Guyana, people come from Guyana, they send the patients to India in charitable missions. Come here, get the surgeries done, pediatric cardiac surgeries, go back. So not that we don't have it. We have it, or like you said.
Thank you, sir, for and giving you all your knowledge, transferring all your knowledge to our students. We are very much, our students are very well benefited by your weekly instructions. Thank you so much on behalf of the management, I think.
So thank you, sir. Thank you once again. We are very happy that you are here. Uh, so I request Ambedkar sir, Sudhir sir, Mahesh Garu, come. Hemant sir, please come onto the desk. So a small token of appreciation to Dr. Bhavani Prasad Garu. So please come onto the desk. Pediatrics PGs and faculty can join. Pediatrics PGs and faculty join. మీరు కూడా allow. So thank you all the PGs and the interns. Hope you had a very good learning session here. Thank you all. Please go to your respective departments and duties. Thank you all. And I want everybody to sign in the books, interns and PGs. Please sign and leave. Huh?